of course we expect. They're effects that we don't want. We expect them to be less onerous than the benefit of the medication. Then there's withdrawal syndromes. We usually still reserve the term withdrawal syndrome to mean that we have provoked a medically dangerous event. Then there's discontinuation syndrome, which is not medically dangerous, but is very disconcerting and uncomfortable for patients. And then there's allergic reactions, which we can maybe predict based on a good history, but often are idiopathic. And then, of course, there's toxicity, where it's not an expected side effect, but we are doing active damage to the person's body. So how do we begin the general assessment of adverse events? Well, you start with a comprehensive initial review of symptoms, absolutely every major organ system, just like an internist would do at your initial evaluation. Cover absolutely everything. You've got to know if there's a pre-existing problem or symptom to learn whether or not you have created an adverse event. A good example is sexual dysfunction. In all of our studies in assessing sexual dysfunction caused by psychopharmacology has learned that if you don't ask patients about sexual dysfunction, they are not very likely to bring it up. So if you haven't asked about difficulty with sexual desire or difficulty with orgasm, and then suddenly it comes up later in treatment, you don't really know if it's an adverse event or a pre-existing condition. So be absolutely thorough initially. And then at every follow-up visit, you want a problem-oriented review of systems also. And this will help you with your triage. Initially, when you hear that there's an adverse event, ask first about compliance. Have there been any missed doses, which may have triggered, for example, discontinuation syndrome? Excuse me. Have there been any extra doses, which might have triggered some toxicity? Have there been inaccurate doses? Hopefully, you're going over this at absolutely every visit, but if this is a phone call or a new visit in between scheduled visits, you're going to need to start with determining compliance. Ask about brand changes, including generics. We all know that our serum levels are based on the bioavailability, and the actual dosing recommendations of a medication are based on the bioavailability of the first medicine to be approved for release and marketing. We know that the serum levels can be changed by the bioavailability changes, which are caused by differences in manufacturing practices. Now, the FDA in the US is very good about monitoring this with factories in the US and shutting down production lines if there's any variation in the bioavailability. However, the law allows a variation of 20% higher or lower in the serum level or bioavailability between a generic brand and the brand name. And it used to be 30%, but it's still 20%. And that's for each generic. So each generic itself might be 20% higher, 20% lower. Unfortunately, since many of the generics are produced worldwide, the FDA doesn't have the resources to go check all those factories. So really, they're not being checked. Unless something egregious happens, we really don't know about it. So if you've had a change in the patient's condition, particularly an adverse event, one of the first questions to ask is, have you changed the brand of the medication? If the patient doesn't know, you need to call the pharmacy yourself and find out. Of course, have there been any new medications added? It's so common for a patient to be on one of your medications, suddenly they call you with a rash, and yeah, their family practitioner actually did give them an antibiotic last week, and they called you, not the family practitioner. And then, of course, is the patient using any as-needed medications they hadn't been using before, or any over-the-counter medications? Again, should be a part of every history at every visit. So is the adverse event expected? Is it tolerable? And is it acceptable to the patient? You want to consider the balance. Is the benefit of the medication greater than the adverse event, like we would consider with most side effects? What are the risks of losing the benefit of the medication if we stop it due to an adverse event? And if so, what is the process of change? A really good example here is lithium. patients taking lithium who eventually develop renal dysfunction. Now, as you'll see in the book, the data proving that lithium causes lithium dysfunction is really not there yet. There might be some hint in big data that maybe we can show it, but the data has been going back and forth for decades. Even if lithium does do this, we're talking low single digits, really, really low incidence. Compare that to the general incidence of renal insufficiency in the general population, which is approaching 20%. So 1 in 5 of our patients are going to develop some kind of renal insufficiency at some point in their life, whether or not it's induced by lithium. And so all of your patients in lithium, 1 out of 5 of them is eventually going to need to be taken off of lithium because we don't want it to build up and become toxic. So this requires a multidisciplinary approach. The nephrologist and you and the patient are all going to have to work together to figure out what you're going to do instead of lithium. You don't just yank the patient off of lithium. You've got to figure out what you're going to do instead. Unfortunately, many of these patients have been on lithium for years and never have tried other mood stabilizers, so you don't even know which ones work. So all I'm putting in a plea here is please do it thoughtfully and slowly, so that the patient still has benefit of treatment. All right, let's launch into the specifics. Discontinuation syndrome. This was identified in the early 1980s. We think of it as being associated with SSRIs, but it really follows the discontinuation of any serotonergic agent. So it's not just SSRIs, it's SNRIs, it's MAOIs, and it's, of course, tricyclic antidepressants. What are the symptoms of discontinuation syndrome? Well, they're flu-like: nausea, dizziness, headaches, fatigue, sometimes severe vertigo, myalgias. Patients may describe electric shocks in their body, and sometimes it even presents as anxiety and agitation, which of course we were hoping to treat in the first place. So we know that because the medication's being reduced rapidly or stopped rapidly, we're also going to see loss of clinical benefit, including a mood drop. Remember that discontinuation syndrome can occur from a single missed dose. The poster child for this is venlafaxine. Even long-acting venlafaxine is very short-acting. So we see this syndrome often with missed doses from venlafaxine. You get a call, the patient says, I'm having all these horrible side effects. What's wrong? You say, did you miss your medicine? Yeah, I missed it 3 or 4 hours ago. You say, take your medicine, it'll be better in an hour. They don't believe you. So it's very important, 1, so that you don't scare your patients, and 2, so that they'll believe you when you tell them how to fix it, that you discuss this in advance, that this is a short-acting antidepressant. If you miss a dose, you may have a rebound in side effects, what we call discontinuation syndrome. Take your medicine, it should be better in an hour. Call me, we'll discuss it. They're likely to believe you if you've anticipated it and described it to them, whereas they're not likely to believe you if you haven't. Another way to minimize the risk of discontinuation syndrome is choosing medications with longer half-lives. At the one extreme, we have venlafaxine. At the other extreme, we have fluoxetine. With its active metabolite, norfluoxetine, has an incredibly long half-life. So it takes 4 to 6 weeks to reach a steady state serum level of fluoxetine. And if you stop it abruptly, it takes that much time to lose it. So if all things being equal, you have a patient that's particularly sensitive to discontinuation syndrome, you might want to think about the longer half-lives. Once we know that discontinuation syndrome is there, of course, the management is to restore the missing medication. Tell them to take it or go back up on the dose if you're the one that prescribed the reduction. Always consider a reasonable taper schedule when you're tapering a serotonergic agent, considering the half-life as we discussed. Reduce the dose by the smallest increment you can every 14 days, and then half the final size or give it every other day for the final 14 days. For most patients, this will work well, but occasionally you're going to have someone who is an outlier, who is much more sensitive, and even though you've gone very slowly, they're going to have discontinuation symptoms. In this case, I would stretch the final dose to every 3 days for several weeks, then every 4 days for every several weeks until the discontinuation symptoms are truly gone. And I want to mention another alternative strategy. Sometimes it's reasonable to change from the shorter half-life medication to one with a longer half-life. Again, say venlafaxine to fluoxetine. If you're going to do this, you have to add the longer half-life medication to the shorter one initially, get both of them together. Because if you're starting one that's going to take weeks to build up, and you're stopping one that's going to be gone in hours, you're still going to provoke discontinuation syndrome and accomplish nothing. So you have to give them on top of each other until you reach the steady state serum level of the new agent, which again can be 3 to 4 to 6 weeks with fluoxetine. And then stop both medications simultaneously. If you don't do that, it's going to take forever to taper the longer half-life medication. The longer half-life agent self-tapers, and you almost always avoid discontinuation syndrome. You just have to be sure, of course, if you're going to do this, that your patient can tolerate having 2 antidepressants together for 6 weeks. Make sure, for example, that they don't have bipolar disorder. We don't want to provoke mania or rapid cycling. Now let's move on to rashes. Of course, rashes can occur from anything. But I want to talk today about rashes from the aromatic anticonvulsants, because of course we're all aware that lamotrigine has a very big risk of this rash and sometimes even Stevens-Johnson syndrome, particularly if you move 2 doses closer together or if you raise the serum of the dose and therefore the serum level too rapidly. So we all know about the recommendations for how slowly to go up with lamotrigine because there's a black box warning. The problem is we have the exact same problem from the other aromatic anticonvulsants, carbamazepine, oxcarbazepine, Dilantin, phenobarb, and they don't have black box warnings. That's the problem with black box warnings. If a medicine doesn't have one, you think you're safe. No, actually you're not. So you need to be thinking about these rashes anytime you're using these agents. The most serious cases usually occur within the first 2 months, but we do see reports of even Stevens-Johnson syndrome after long periods of stable treatment. Most of these rashes are going to resolve spontaneously without discontinuing or lowering the medication. But occasionally it may require discontinuation of your treatment. Now, you'll find that as a practitioner, you're going to have a personality about this. Some of my very finest colleagues are much calmer about this and will wait and see if the rash goes away before they discontinue the medication. Personally, I've always been at the other extreme. I want them off of something that's causing a rash because I don't want it to get worse. It can work well both ways. You just have to remember that your patients need to know that you want to evaluate and monitor every single rash, and you're going to do it with concern. It's urgent when there's a fever, a deterioration of mucous membranes, blistering, pain, rapid spread, or trouble breathing or swelling. This is an emergency, and they must seek medical evaluation from a facility immediately. Now let's move into serotonin syndrome. The most important thing to learn about serotonin syndrome is it's not idiopathic. It's going to happen to anybody who has a high CNS serotonin level. We tend to think of this as coming from multiple medications that affect serotonin, but be aware that actually it can come from a single medication. Particularly in this case, usually it's at higher doses and with medications that have the longer half-lives, as we've been talking about. The psychiatric medications that are serotonergic, of course, we think of the SSRIs and the SNRIs. But remember, MAOIs do this too, as do trazodone and buspirone. Second-generation antipsychotics, particularly at lower doses, stimulate serotonin. Even methamphetamine and even some weight loss medications. And then there are plenty of non-psychiatric serotonergic medications to worry about. Cough and cold treatments, many of them over the counter, chlorpheniramine, cyclobenzaprine, dextromethorphan causes all kinds of problems, including this one, and codeine. And then here we are at pain medications, codeine again, tramadol, methadone, fentanyl, hydrocodone, meperidine, oxycodone. Hopefully these are being reduced in prescription, but they're still out there. Migraine treatments. If you get an alert from the pharmacy with their automatic drug-drug interaction program they're usually going to tell you, you've got a patient on an SSRI and you've given them a triptan. We all get that almost every day. But it's not just triptan, it's also ergotamines. And then even dietary supplements like L-tryptophan. Those of you who heard my last webinar on supplements heard me make a big point about St. John's wort being a risk in combination with antidepressants for serotonin syndrome. It weakly stimulates serotonin. It does not treat major depression in any way, and no one should be on it. But if patients are doing this on their own, they could be provoking serotonin syndrome. And then it's not just dose, it's not just polypharmacy, there's also drug-drug interactions to worry about. Because of the 2D6 inhibition, as you can see here, fluvoxamine, fluoxetine, paroxetine, bupropion, sertraline, HIV antivirals, ziprasidone are all going to make it more likely to have a higher serum level of the serotonergic agents and provoke serotonin syndrome. Same with 3A4 inhibition, again, fluvoxamine, norfluoxetine, verapamil, or even erythromycin. What is the presentation of serotonin syndrome? Well, unfortunately, this is highly variable. It ranges from minimal to lethal, and the deterioration may be rapid. Most often, patients present with mental status changes, which of course they're coming to us for in the first place, autonomic hyperactivity, and neuromuscular abnormalities. The mental status changes usually appear as agitation or delirium. The autonomic hyperactivity involves tachycardia, diaphoresis, mydriasis, nausea, vomiting, diarrhea, active bowel sounds. There are neuromuscular changes, which are also very important to note. There's a tremor, which is of course nonspecific, but the very most specific symptom for serotonin syndrome is actually clonus. It can be spontaneous, inducible, or ocular. Unfortunately, however, hypertonicity may also develop, and this will suppress your clonus. So you can't say the patient doesn't have serotonin syndrome just because I'm not seeing clonus. Hyperreflexia is also common. When a patient walks into a medical facility and complains and they have serotonin syndrome, the most likely complaint is going to be headache or dizziness. Unfortunately, not at all specific. Fever is possible, but hyperthermia is less common. What are the diagnostic tools? Well, if you're reading my chapter or you're reading the books, you're going to read about these criteria. They're useful for research. They're useful in academic or tertiary care settings. You don't need to remember them. But I just wanted you to hear about them in case you read about them. The 100 criteria were first, they focus on the physical symptoms. The Sternbach added mental status changes, and Radomski added a severity. I just want you to be familiar with them. Don't worry about memorizing them. How do you make the diagnosis of serotonin syndrome? The very best way to do it is to be aware of the potential. Be aware of what your medications are doing. With your full knowledge of pharmacodynamics and kinetics, you know about whether or not they're affecting serotonin, you know about if there's any impending drug-drug interactions, and if you're aware that a patient on these medications could have serotonin syndrome and they present with problems, it needs to be at the list of your differential. This is much more useful than trying to nail it down by specific symptoms or criteria. The differential includes neuroleptic malignant syndrome, which we're going to go into in a minute, but also CNS infections, anticholinergic poisoning, and general sepsis. What is the treatment? Discontinue all serotonergic agents. Hospitalize even mild cases for observation, supportive treatment with fluids, and stabilization of vital signs. Remember, the patient's condition can deteriorate rapidly and it can be lethal. And this is also important. When a patient walks into, say, an ER, the staff is used to giving antiemetics when they're having nausea and vomiting, which could be a symptom. They love ondansetron. You have to remember as a psychopharmacologist, if they don't, that ondansetron is serotonergic. So for heaven's sakes, don't allow them to give that. In severe cases, support for respiration and circulation will be necessary. Hyperthermia can be addressed with cooling, and you might need serotonergic antagonists like cyproheptadine. Never delay appropriate referral for intensive care treatment. What are the key points then about serotonin syndrome? Discuss this in treatment planning so your patients can help monitor their own serotonergic use. be aware and remain at the risk, and report the symptoms to you quickly. Let's move on to neuroleptic malignant syndrome. I know you've heard of this. Thankfully, it's rare. Unfortunately, when it does occur, it has a very high mortality rate, greater than 5%. So we all need to be aware of it. Unfortunately, it also has a variable presentation and winds up being a diagnosis of exclusion. What is the risk? Well, we think of it as being from major tranquilizers, but it's from all dopamine antagonists and even partial agonists like aripiprazole. How do you make the diagnosis? Well, again, early altered mental status, delirium, stupor, coma. And this is very difficult because you're generally giving major tranquilizers to patients who have psychosis. And they may present with catatonia, which early on looks a lot like NMS. So that's very difficult to make the diagnosis. The presentation usually includes severe systemic lead pipe rigidity. This can lead, of course, to rhabdomyolysis, which you can check for, hyperthermia, and again, autonomic dysfunction. The differential, again, includes CNS infections and disease, malignant hyperthermia from anesthetics, abrupt discontinuation of dopamine agonists, heat stroke, again, serotonin syndrome, central anticholinergic syndrome, and even lithium intoxication. What is the treatment? Discontinue the dopamine blocking agent. Provide respiratory and volume support, monitor electrolytes. Emergency hospital-based intensive treatment is always needed. There have been studies showing that bromocriptine, dantrolene, piperidine, all can be useful individually or in combination. However, there are no randomized clinical trials showing that benzodiazepines or amantadine can be helpful. Now, when you're reading about NMS, you'll read sometimes about ECT as a treatment, but just make sure that we understand the fine print. They're not talking about ECT to treat NMS. They're talking about ECT to treat the underlying psychosis that you're no longer treating because you're trying to respond to NMS. What are our key points for this problem? Again, your awareness of the risk is your greatest tool in diagnosing and responding to it. And always hospitalize for intensive treatment. Now we're going to move into movement disorders. And I want to begin with withdrawal dyskinesias. We all know about tardive dyskinesia, but there is a thing called withdrawal dyskinesia where the patient's not having a particular dyskinesia until you stop or rapidly withdraw the dopamine blocking agents. Again, it just occurs in the absence of tardive dyskinesia. Happily, these are usually brief and self-limiting and no intervention is necessary. I mention it because you have a patient who's not having a dyskinesia, you stop the medication, it appears. You don't want to necessarily just put them right back on the medication to block it. What you want to do is give it a few days to see if it goes away because over 80% of the time, that's what's going to happen. Now let's talk about acute dystonic reaction. I'm sure most of you who were interns in psychiatry remember this. This is probably one of the first things you learned. It's basically a sustained muscle contraction or cramp that occurs acutely. It can involve oculogyrate crisis where the eyes roll up into the head. It doesn't cause any long-term damage and is rapidly reversed with either oral or intramuscular anticholinergic medications, the most common being diphenhydramine or Benadryl or benztropine or cogentin. Now let's move to extrapyramidal syndrome. Those of you seeing patients on a weekly to monthly basis with major tranquilizers are well familiar with this. It's also called Pseudo-Parkinsonian Syndrome because, of course, it mimics Parkinson's disease. So you'll expect to see the resting pill rolling tremor, bradykinesia, flat facies, cogwheel muscle rigidity, which hopefully you're checking for. I want to point out one problem in the assessment that has shown up. The neurologists now have this thing called dopamine transporter protocol. I put on the slide the 2-line name of this procedure. Again, you don't need to memorize, but I just wanted you to see. They're using it to differentiate Parkinson's from essential tremor and EPS. The very best people in the field, though, will tell you that the interpretation of the study is highly subjective. It takes a lot of expertise to really get this right and to know what their data says. So many people doing this procedure, even though they mean well, are probably not going to be interpreting it correctly. And this can raise difficult and misleading dilemmas for patients. If you've got a patient who has EPS and they go into the neurologist for further evaluation, and then they're told everything's blamed on your medication, and this is a patient with chronic psychosis, we've got a dilemma. So I'm just recommending that you be aware of this tool. And when somebody comes in and says, I had this protocol done and they tell me it's all due to my medication, you want to go back to the person doing it, discuss it with them in detail. What is the treatment for EPS? Well, we're always told to minimize the dose if possible. And as you probably know from practice, yeah, you can do that, and they're still going to need the treatment and they're still going to have the problem. So you might want to add in either benztropine, triaxphenidol or arcane, or amantadine. Now, what are the problems with doing that? The problem is when you add in an anticholinergic medication, you're not only going to have our standard anticholinergic side effects of dry mouth, constipation, and urinary retention, but we're also increasingly aware that we are probably causing at least temporary cognitive impairment, not necessarily long-term, but certainly in the short term while they're on it. And then remember that anticholinergic medications also increase the patient's risk of developing tardive dyskinesia and worsen it as a symptom. And then amantadine, of course, affecting dopamine, may worsen psychosis. So you don't necessarily get this treatment for free. All right, now, tardive dyskinesia, of course, something we all want to avoid. It's a late onset involuntary movement disorder linked to dopamine receptor blockade from antipsychotics. Most of us know that well. The reason we don't like it is because it persists beyond the use of the causative agent. You stop the antipsychotic and they still got tardive dyskinesia. And it's not necessarily the withdrawal dyskinesias that I talked about earlier. How does tardive dyskinesia present? Well, we call it tardive because we really expect it the patient to be on the medication for about 3 months before the symptoms emerge. But actually, we know well that it can occur from single doses or early doses. It may affect any muscle of the body. It's obviously most onerous on the face or the upper or lower extremities. Thankfully, it rarely affects the diaphragm, but it can. What's our differential diagnosis? Well, again, we look at all the other movement disorders, and we can easily distinguish tardive dyskinesia by timing of onset, its nature, and the response of treatment to these other interventions, the ones I mentioned, acute dystonic reaction, EPS, and withdrawal dyskinesias. The older treatment strategies for tardive dyskinesia involve stopping the dopamine blocking agent, which often didn't do anything. And of course, the patient goes without treatment. The other strategy was to raise the dose. Now, this would help temporarily. You would block the movement disorder for a time until the medication caught up, and then it would return. So you'd be steadily raising the dose and eventually winding up exactly where you were. That's kind of a failed strategy. What are newer strategies? Well, whenever you can, choose a second generation antipsychotic medication rather than a first generation. The reason is that the incidence with the first generations, like say haloperidol, has a 5% annual incidence of developing tardive dyskinesia. So after 1 year of treatment, 5 out of 100 patients are going to have it. After 10 years, 50 out of 100 are going to have it. But with the second generation antipsychotic medications, even the weak agonists, what we found is the incidence is less than 0.5% or 1/10 or more less. So whenever you can, to avoid tardive dyskinesia, you want to think about a second generation agent, not a first generation agent. And as we said earlier, minimize the use of anticholinergic medications. There are 2 FDA-approved medications for the treatment of tardive dyskinesia, valbenazine and its deuterated version. But I want you to be aware and make sure your patients are aware that basically these medications in most cases improve things by 40 to 60%. They don't necessarily make the tardive dyskinesia go away. They may just ameliorate some of the symptoms. So the key points for tardive dyskinesia is that dopamine blocking agents should never be used for treatment without full disclosure. I can't tell you how many times I see in my patient practice a patient coming to me who's been put on 25 milligrams of Seroquel for sleep by a non-psychopharmacologist. This I can bet you, and I ask every time that that patient was not warned about tardive dyskinesia. There are so many better ways to help with sleep. So you must give your patient the opportunity to give informed consent about the risk of tardive dyskinesia. And then you're probably going to need the AIMS, the Abnormal Involuntary Movement Scale, or some other scale. It's easy to use in your session. It doesn't take long. Patients will work with you on it, and you can document in your notes any movement disorder progress. And again, let's go back to the movement disorder consultation. You don't want to send a patient to, say, a movement disorder specialist for a tremor who says, oh, well, you've got a tremor from that medication, just stop it. You know, I mean, that's just really not helpful to your patients. So what you want to do is develop a working relationship with movement disorder specialists who understand our patients and their needs and carefully consider the risk of avoiding medication so we can all discuss it together. Now, finally, we're going to talk about suicidality. We know in terms of suicide risk that psychiatric patients in general are at greater risk than non-psychiatric medical patients and the general population, patients and non-patients. We know that the risk is greater for any patient expressing suicidal ideation than those who don't. The old saying that people who talk about it don't do it, as we know, is false. The risk of suicide increases as recovery from severe depression begins. We have known this, and our older colleagues have known this since the early days in the 60s and the 70s with antidepressants, that a patient who's morbidly depressed and doesn't feel like getting up and doing anything, like making a sandwich, also doesn't feel like getting up and killing themselves. But in the first few weeks of treatment, as they begin to feel better, and they do feel like making that sandwich, they actually might feel like going ahead and killing themselves too. So this has always been known and should always be monitored carefully. Additionally, however, in the 1990s, we began to see in the literature concerns about increasing suicidality from antidepressants. Now, frankly, most of these studies weren't very good. They were case reports that didn't take into account whether or not the patient was bipolar. It just was alerting people that there might be a problem. And also, the early use of the term suicidality was totally inconsistent. Everybody meant something different by it, so it was difficult to study. And then we have to also realize that this all takes place with the background of a suicide rate in the US and the world steadily climbing. By 2007, the FDA said, all right, we need a clear definition we can all agree on of what's suicidality. And this is what they came up with: a suicide attempt, preparatory behaviors, suicidal ideation, self-injurious behavior without known intent. In other words, don't try to guess whether they were serious or not, just include it. And then in randomized clinical trials, if any suicidal ideation or behavior occurs, it gets counted as a suicidality event. This definition, the application of this definition, resulted in a reduced estimate of risk from the 90s to the 2007. The CDC in 2011 suggested that we even quit using the term suicidality and use the phrase suicidal thoughts and behavior, which is a terrific idea, but really this hasn't taken hold. By 2009, 125 different prescription medications carry black box warnings from the FDA about suicidality. Antidepressants, soporifics or sleeping pills, anti-anxiety agents, antipsychotics, anticonvulsants, everything we use. The big warning was in 2004 when the FDA expressed concerns about use of antidepressants in children and adolescents provoking suicidality. After that warning, the prescriptions for all psychotropic medications at all age groups dropped, particularly for antidepressants and for prescriptions in children and adolescents. It's interesting, though, that by 2009, when we had our when we still had 125 prescription black box warnings, The prescriptions for all psychotropic medications, though, had gone back up to the previous levels. Obviously, the need was apparent. Let's talk about what research has told us about suicidality. Suicidality is often an exclusion criteria for random clinical trials. That means that if you show up and express any suicidality, they don't want you in their study. You shouldn't be included. So generally, it only happens when it appears or somebody was sloppy. This results in problems with internal and external validity. In other words, we shouldn't be trying to use randomized clinical trials to study suicidality when we specifically excluded it from those trials. But this has not stopped anybody from going ahead and trying to draw conclusions. So what we have learned is that there's a rare increase in suicidality along with treatment efficacy associated with active antidepressant treatment in children and adolescents. We know in random clinical trials of 7 antidepressants, there was no difference in the rates of suicide and attempted suicide between active drug, active comparators, and placebo. Pharmacoepidemiological studies have shown antidepressants to provide protective effects against suicidal events for all patients of all ages. Longitudinal data from treatment of major depression with fluoxetine and venlafaxine in adults, geriatric patients, and youths showed a significant reduction in suicidality in addition to other clinical benefit. And data has also shown that in use, depressive symptoms sometimes improve without a reduction in pre-treatment suicidality. We're going to come back to that. Meta-analyses of random clinical trials have found support for fluoxetine use in children and adolescents. Has it been criticism of the research? Well, I've already talked about the difficulty of using random clinical trials to study it when there are exclusionary criteria. Additionally, there's a greater incidence of suicidality in our patients to begin with, prior to treatment with medication. And this confounds the estimates of pharmaceutical risk, and we call this residual confounding by indication. Many studies fail to adequately exclude patients with mixed or depressed bipolar disorder, as I said. Calculation of suicidality with non-psychotropic medications has not been successful at all. We don't know how to compare it to our medical brethren. And increased risk of suicide with the use of anticonvulsants has not been confirmed due to the heterogeneity of studies and residual confounding, even though there's that black box warning. Well, what can we say? Well, we do know that benzodiazepines may worsen suicidality when used without antidepressants. This should always be a concern. We know that comorbid substance abuse significantly increases suicide risk. So that's something to be monitoring. And then even non-treatment factors, including high affective lability, is correlated with suicidality. Early suicidality may go unrecognized as treatment proceeds and be misattributed as an adverse event. So if not everybody prescribing antidepressants is asking every patient at every visit about suicidality. So that may lead to a misunderstanding of what's an adverse event and what was a pre-existing condition. So what can we do? We can assess every patient at every contact for suicidality. We can explain FDA warnings to our patients and family prior to prescription, but we can also emphasize individual treatment plans to minimize the risk of self-harm. So our key points about suicidality. Recovery from psychiatric syndromes with indicated medication will largely outstrip any demonstrated risk from utilizing those agents. Proper monitoring following guidelines from legitimate literature offers the best outcome and safest path for most patients. What are our key points about adverse events in general? Adverse events occur at incidences greater than desired. So let's anticipate them and discuss them at every visit. Document a complete review of systems during the initial assessment, so in your follow-up review, you can clarify what's truly the emergence of an adverse event. The full history will clarify compliance and interference of new treatments from other providers, over-the-counter medications, and PRN medications. Don't just assume it's the medication that the patient's asking you about. Discontinuation syndrome may be iatrogenic. We may have given an ill-advised prescription, or due to poor compliance, patient missing their medication, but it can be effectively managed if we anticipate it. Serotonergic syndrome is not idiopathic, but specifically related to anyone developing high serotonin levels from dose, polypharmacy, or drug-drug interactions. Tardive dyskinesia may develop from the use of all antipsychotic medications and is usually permanent despite our new treatments that reduce symptoms. Antipsychotics should never be prescribed, therefore, for any indication, even briefly, without disclosing the full risk of tardive dyskinesia. NMS is a rare but potentially lethal complication of dopamine antagonists that's difficult to distinguish from catatonia during psychosis and is easily confused with serotonin syndrome. Despite warnings of increased suicidality for many medications, this risk has still not always been confirmed. We can effectively manage that risk, however, by fully evaluating suicidality at every single patient contact so that individualized treatment plans can be developed and altered as necessary. That's my presentation. I'm happy to take questions. You can reach me at my email address if you have questions. Also, there's additional information and links to the book on my webpage, drpaulputman.com. Thank you. So now I'll open it up for questions.
That was fantastic, Dr. Putman. Thank you so much for this lovely presentation. I believe Darshana had a question. What are the treatments? Excuse me. What are the treatments for depression and anxiety in geriatric patients with Parkinson's? And then
what are the treatments for major depression with geriatric patients in Parkinson's? Was that the question?
Yeah. What are the treatment options for depression and anxiety in geriatric patients with Parkinson's on treatment with raceglane and MAOB inhibitor?
Okay. I'm now working on a new book that's about treatment-resistant depression. And hopefully we'll have a webinar about that at some point. And I guess my simple answer is, let's not assume that everything is treatment-resistant depression. Let's just assume that we haven't figured out what the problem is here yet, and that we're going to figure it out. Is it another medication that's interfering? Is it another diagnosis, medical or psychiatric, that's interfering? Are we treating the wrong diagnosis because that's not the right one? So you can read in the literature many different recommendations for treatment-resistant things that you should be tailoring to specific populations. And I'm not saying that's wrong. I'm just saying that you don't necessarily need to start with the extremes. Don't start with the assumption that it's an outlier. Let's just start with the general treatments. Most treatments are going to work for most patients. So I don't think we need to exclude the standard treatments. I would try the standard treatments first, because you're going to be most familiar with those and you're going to be able to anticipate any adverse events from those more readily. So that may not be what you were hoping to hear, but I definitely think that's the way to proceed.
Okay, thank you. And thank you, Dr. Putman. We have one more question. I have been told that lamotrigine must be tapered off slowly to prevent SJS. I've been told that it is safe to stop it abruptly. What are your recommendations?
Well, there isn't any, I'm not aware of any data that says that stopping lamotrigine abruptly is going to increase the patient's risk of Stevens-Johnson syndrome. I've never seen that anywhere. If there is data, of course, I'm open to seeing it. I've just never seen it. And rationally, why on earth would we expect that? The reason that the rashes occur and sometimes Stevens-Johnson syndrome occur, I mean, Stevens-Johnson syndrome is idiopathic. We don't really know what causes it. But if we're assuming that it, like the rashes, is related to a very rapid rise in the serum level, then a rapid drop in the serum level just doesn't really make sense. Now, of course, again, as I've said, when you're taking a patient off a treatment, you've got to be aware that they're going to lose all the benefit and you're back to the original problem. So I'm not saying that you should or should not stop lamotrigine abruptly, but if you are stopping it abruptly, I don't see any data or any rationale that says you should worry any more about Stevens-Johnson syndrome than you did before. Just be aware, as I said, that sometimes it'll just show up in patients that have been on stable treatments for years. So be aware of it, but I don't think you're provoking it with a rapid discontinuation.
Okay. And then Aizan has a question. Have you seen TD on lamictal Wellbutrin?
Well, that's a good and interesting question. The early data, early research on tardive dyskinesia always held out that it can occur spontaneously. And I'm not aware of anything that's changed that. So sometimes people just get it, or we think they get it spontaneously, because of course we don't have a complete enough history of everything that's ever happened to them in their lives. Maybe somebody gave them something they weren't aware of or didn't recall. But we do allow for spontaneous appearance of tardive dyskinesia. So I'm not aware of any links to it from Lamictal or from Wellbutrin. And again, rationally, I wouldn't expect them.
Okay, and then he has one more question is, what would you suggest for sexual side effect from SSRI if bupropion isn't an option? Yep, bupropion.
Yeah, good question. And this comes up all the time in practice, as you know. Well, of course, you're going to have the greatest incidence of sexual side effects, around 30% from SSRIs. You're going to have about 15% from SNRIs. And you should have none really from bupropion. So if you started a patient on SSRI, you're pleased with your response, and you want to not lose it, you're exactly right. Many people add bupropion into it. When you do that, of course, what you're doing is you're changing from an SSRI to an SNRI. You're just doing it with two medications. And then, of course, you're going to get the response to an SNRI. It's like changing medications. Maybe you'll get the same response. Maybe you won't get the same response. If bupropion isn't an option for many other reasons, then, of course, you can't do that. So you might go ahead and change the patient to an SNRI. Odds are you'll still get a pretty good response, maybe not as good, maybe better, and you cut the risk of the sexual side effects in half. And then, of course, that's probably the best thing I would do, would be go ahead and change to an SNRI yourself rather than creating an artificial one with bupropion.
And then Aizan adds to it that what if you still have a side effect? Do you recommend Viagra?
No, I don't. And it's a little silly how Viagra got started. Remember, Viagra is very mechanical. It works to increase the sphincter control, maintaining the blood in the penis. So it's a mechanical thing. For some reason, people started giving it to people to see if it improves sexual side effects, forgetting its mechanism of action. It really shouldn't do anything to improve sexual side effects except for tumescence. So no, I know you can read poorly done studies about it, but I don't think that you should expect the Viagra will have any benefits whatsoever. People have tried amantadine, they've tried a whole bunch. And again, if you look at the chapter in my book, I go into all the different things people have tried. And unfortunately, there's just not another good outcome. I think what you should try to do is find another treatment that will work as well for their mood disorder as your SSRI.
Okay, I believe John had a question which said, the sexual side effects can be from an excessive dose. I had a patient on 20 milligram escitalopram and reduced him to 10 milligram. His PHQ-9 and GAD-7 were unchanged. His sexual drive was increased.
Certainly, as we were saying with the major tranquilizers and EPS, anytime you can reduce the dose and sustain the benefit and reduce adverse events, that's wonderful. And you should be thinking of that. That's really good practice. Unfortunately, it's not always possible, but you should try it, yes.
Okay, and then Aizen added to his previous question, have you seen switching to Trintellix to help a sexual side effect?
Well, there's seeing and then there's knowing it works. Yeah, people try everything. I'm not aware of any data that would back that up. Again, my recommendation is you find a treatment that will work better. I'm not against that. I'm just not aware of any data backing it up.
Okay, fantastic. I think that those are all the questions we have. Does anybody else have any questions? Any closing comments? Okay, thank you so much, Dr. Putman. It was wonderful, and I appreciate your time. Thank you so much.
Thank you, everyone. Have a good day. Bye.
Thank you. Bye-bye.